Dr. Emily.
All right, thank you so much for having me, and thank you for that introduction. I'd also like to specify that my particular area of expertise is immunocompromised patients, and so these are the people that I'm routinely seeing in the hospital and in my clinic. And these are really people that I care about quite a bit when it comes to infections and COVID-19. To get started, I wanted to introduce, why is this an area of focus? And that's really for two reasons in 19. For immunocompromised patients, which are really patients that have some deficit in their immune system, either because we've given them drugs to do so, for example, chemotherapy, or because they have an innate deficit. They are both at risk of severe COVID-19, so having higher risk for hospitalization, higher risk from death from COVID-19, and also at higher risk from not responding to vaccines. Because you need an immune system to respond to vaccine, any deficit in immune system can make the response less than what we want. And so we have two problems going on where we now have a very vulnerable part of our population among patients with immune deficits. And so I think that's why we're talking about those patients today. This was pretty well recognized over the summer that immunocompromised patients, and specifically those with organ transplants, those on cancer chemotherapy, those who've had stem cell transplants, and those who are on other immune modulating medicines, we found that they have just not responded to their primary series of vaccine as well as people without all of those things. And so over the summer in August, a third dose was authorized for those patients, a third dose of mRNA vaccine. This is supposed to be recognized as a third dose and not as a booster. And that's important for a big reason, which is that the primary series for immunocompetent for patients or for the general population is 2 doses, but we think immunocompromised patients at least need that third dose to get them to a good level of protection, if not more than a third dose. And so that third dose is really to be considered their primary series. And just like everybody else, that means that immunocompromised patients are due for a booster, but instead of that booster being their third dose, that booster is now their 4th dose. As of Friday, the ACIP and the CDC made clarifications that booster can happen 3 months after the third dose, which if you received your third dose in August, has either passed or you're due for your 4th dose now. So I think this is a great time to be talking about it because most of our immunocompromised patients are set to should go out and get their 4th dose of mRNA vaccine.
Thanks, Dr. Emily. So what is the process for getting this 4th dose? Do these immunocompromised patients need some kind of doctor's permission, or how do they go about getting it? And what types of immunocompromised people are we talking about? Can you talk about some of the conditions?
Yeah, so immunocompromised, just like I said before, is either an innate condition or a drug that can compromise your immune system, as the name suggests. These fall into several categories. Solid organ transplant recipients, essentially any time after transplant while they're on immunosuppression, are part of this group, and a large part of this group. Stem cell transplant recipients, patients with cancer who are on active chemotherapy, and then patients with any sort of innate deficiency of their immune system, and then kind of a wide variety of patients who have autoimmune conditions or neurologic conditions where we give medications to compromise their immune system. Some really important drugs in that class are things that specifically compromise your ability to make antibodies. So patients who are getting antibody, B cell depleting therapy, B cells being the cells responsible for generating antibodies, things like rituximab or ocrelizumab, which are frequently given for neurologic and rheumatologic conditions. So that's really who we're talking about when we talk about immunocompromised patients. This can also include steroids. I should have mentioned that. And then with regard to getting your 4th dose of vaccine, this should be offered in your hospital clinic at the University of Utah. We are offering 4th doses, as well as at commercial pharmacies. What is a challenge for people to navigate is there's a lot of information and misinformation and confused information out there about who is due for what when. And so I cannot promise that every commercial pharmacy has updated their slot and their scheduling so that people can receive that 4th dose. However, they should in the near future, and you should be able to schedule a fourth dose at a commercial pharmacy or at your healthcare clinic. Certainly at the University of Utah, we are offering those for patients who kind of meet these immunocompromised designation. You do not need a doctor's note or a prescription to do that. And it is self-identification.
Okay, that's what I was just about to ask you, is can you just walk in and get it? So what is the timing between doses?
So the primary series, so the first 3 doses of mRNA vaccine, the first 2 doses are either 21 days apart or 28 days apart, depending if you're talking about Pfizer or Moderna. That hasn't changed. The third dose should be 28 days or more after your second dose, and that's true for Pfizer and Moderna. And then the fourth dose now should be 3 months or more after your third dose. So a lot of different numbers and sort of shifting around with different recommendations and guidelines that may still in the future change. And we don't know yet about, will there be a 5th dose, will there be a 6th dose, et cetera. For people who have received the Johnson & Johnson vaccine as their first dose, originally a primary series was just that 1 dose. For immunocompromised patients, it's now recommended if you got a first dose of Johnson & Johnson vaccine, that a second dose with an mRNA vaccine, so Pfizer or Moderna, should be obtained. I believe that's a month after the first dose. And then again, a booster dose is also warranted for immunocompromised, as well as everybody who've gotten Johnson & Johnson. And there can be a little bit of a mix and match strategy, so either Johnson & Johnson or an mRNA vaccine for the booster dose.
Okay, thanks, Dr. Emily. We have a question here. Is the 4th dose for this group a full dose, or is it perhaps a smaller booster dose? And then I have a follow-up for you after that.
Yes, so great question. So this is, again, lumping sort of the primary series, which the third dose counts as part of the primary series, and then this 4th dose is counted as a booster dose. And so the dosing follows the designation of booster or primary series. So for the Pfizer, I believe the dose is, the dose is the same for a booster or for any of the primary series vaccines. For Moderna, the booster dose is smaller. And so that would be true for immunocompromised patients as well. So it follows kind of the designation. If you call it a booster dose, it should be the right dosage in milligrams as for the general population.
Okay, now are there any medical conditions or people for whom the vaccine just really isn't working at all? They're not getting an immune response?
That is a great question. And I want to kind of take a step back and talk about what we mean by vaccines working or not working, and also talk about how we know anything about these patients, because they both play into that answer. For starters, when we talk about a vaccine working or not working, it's really important to, after you say vaccine working or not working, follow it up with, what are we talking about it working for? And there's 3 primary things that are often reported. First off is, does it work against symptomatic infection? Whether you get fevers, whether you get chills, whether you get a cough, et cetera, any kind of symptoms. Second, does it work against severe illness? That's often measured by, did you need oxygen during your course, or did you need to be hospitalized? And third, we care about, does it work against death, against COVID-19 associated mortality? And again, in these immunocompromised patients, when we're talking about them, they have a higher risk, with any vaccine strategy, they have a higher risk of severe disease and death, whether we're talking about 2 doses, 3 doses, 4 doses, et cetera. And unfortunately, we can't change that. What we can do is, try and change our vaccine strategy to make immunity as good as we possibly can. The second thing I want to talk about is how we get data, how we get knowledge about how well vaccines work. And I think it's very hard to navigate the literature because all of the data we get is reported as a population. So we look at groups of patients, we don't look at individual patients, and we decide what happens based on that group of patients. And then as a physician, I'm looking at the patient in front of me and saying, how well do they fit into that group? If so, I'm going to make recommendations based on what I saw in that group. And so when I can say, a vaccine will work this well or not this well, I'm really talking about for patients who fit into this immunocompromised group. What I don't know is how well will that vaccine work for you as a person? And so those groups are made up of people, some of whom have great responses, some of whom don't have good responses. But as a physician, I don't get to know, who has a good response, who has a bad response. I only get to know what happens at the population level. And so that can sometimes frame, how we think about how well vaccines work or don't work. It's not a 0 or 100%, 0 or 100% sort of outcome. So there's no group for whom I would say the vaccines work 0%. Because when I'm thinking of symptomatic infection, when I'm thinking of hospitalizations, when I'm thinking of death, we know that a vaccine strategy decreases, especially those more severe outcomes in any group of people we look at. However, that doesn't mean that some patients will continue to die, will continue to have hospitalizations despite even 4th doses, even if we progress to 5th or 6th doses. So the short answer is no, there's no population for whom vaccine works 0%. However, there are populations, in particular those with who have deficits of their B cells or T cells, so stem cell transplant patients, patients on B cell depleting therapies like rituximab, patients who need antibody replacement routinely because of a leukemia. So a lot of those patients that I listed earlier, there are patients who will have a very low response and will have a high rate of breakthrough symptomatic disease. But as you look at hospitalizations and death, there still seems to be some protection. So that was a very long-winded way of saying that we think that vaccination, is still a recommended strategy for all of these patients because it will, prevent especially severe outcomes in at least a portion of these patients, where if you did not get vaccinated, that could still happen.
Thanks, Dr. Emily. And we have a couple questions about, do we anticipate that this second booster, this 4th shot, will be used for the general population, those who are not immunocompromised, especially given a study that recently came out showing effectiveness of the booster wanes after about 4 months. What are your thoughts on that?
Yeah, I'm glad you brought that up. If we're talking short answers and long answers, the short answer here is we don't know yet. And the longer answer has to do with, what is coming and our ability to sort of predict the future. This 4th dose that we're talking about for immunocompromised patients is actually their first booster dose, right? Because the 3rd dose is actually part of their primary series. So in that way, immunocompetent patients have had 1 booster, and immunocompromised patients, after they get their 4th dose, have also had 1 booster. So the question is really, will there be more boosters after that? I think that really relies on what will we see in terms of developing variants, what will we see in terms of circulating community spread. And I don't know that answer yet. So it will really depend on how much spread we continue to have and what we next see in terms of variants and variants that escape our current vaccine strategies.
Okay, so given the current Omicron situation, let's say a person who is not necessarily immunocompromised, maybe has a health condition or maybe is older, can they just walk into the pharmacy and get this 4th shot?
So I hope I don't get in trouble here with the powers that be. So really, if you are willing to say you're immunocompromised, I believe you could get the 4th shot. The bigger question is, do you need that 4th dose? And I would say if you have medical conditions, but none of them affects your immune system, you probably have had a good immune response to the vaccine. And so again, even with waning antibody responses and waning responses to symptomatic infection, your response to vaccine is probably up there with the general population. The CDC is really looking at this population level data. And so they would be the ones that will respond most quickly to the, does waning immunity mean that we need to sort of roll out a booster dose in the general population, a second booster dose for the immunocompromised population? And I don't know that answer yet. But I would say that for patients with risk of severe disease because of other medical conditions, but who are not immunocompromised, you should expect that your immune response is pretty similar to the general population, not more similar to the immunocompromised population.
And maybe talk it over with your physician and see,
Yeah.
Okay. And then for what do those who are immunocompromised, what should they be doing to protect themselves, and what can the rest of us do to protect them?
I think that's a very good question. I'm going to start with that second one first. What can the rest of us do to protect our immunocompromised patients? As I said before, this is the patient population that I see in my clinical practice. And so this is a population near and dear to my heart. And this is a population that's truly a vulnerable population that's out in our community. These patients are working jobs just like everybody. They're going to school just like everybody. But it's really a population that needs to be protected and needs to be protected by the rest of our actions. The things we can all do to help immunocompromised patients are some of the things that have been going on this whole time. Masking to protect, any sort of respiratory secretions from circulating and potentially infecting a vulnerable person. Getting vaccinated and getting fully vaccinated, including boosters, especially if there's any additional boosters that are recommended to prevent yourself from getting infected and having, shedding high viral loads. And being very careful not hosting large gatherings in public, even large family gatherings with multiple households, et cetera. So some of these same sort of public health measures that have worked or not worked when we've employed them this whole time are really what we can all do to help our immunocompromised community members, because these are people that are in our families. This may be someone, you may be immunocompromised, people I'm speaking with. This is an important patient population, and to only focus on those patients should protect themselves. I'm not going to do anything myself to protect some of our community members is really a problem. So the second thing is, what can immunocompromised patients do to protect themselves? Because we are using as many layers of protection as we possibly can. There's more availability of high filtration masks, and so high grade masking, especially when you're out in public in an indoor setting with other people, is absolutely recommended. So looking at N95 or higher filtration type of masks. Again, fit and filtration is the most important. And I would add a third category, fit, filtration, and can you actually wear it for a long period of time? Because if it's uncomfortable and you take it off, it's giving you no protection whatsoever. So masking, again, distancing and putting yourself in situations where there are fewer people is another, one of these tried and true public health measures that we can do to protect ourselves. The other thing is that there is more and more development of medications that can be preventative. So they're called pre-exposure prophylaxis, meaning they prevent you from getting SARS-CoV-2 even before you've been exposed. The one that in particular that we have right now that's authorized is called Evusheld, and it's a monoclonal antibody. So it's an antibody against the spike protein, and it's made up of two individual monoclonal antibodies, silgavimab and tixagevimab. And when it was actually studied, it was in the pre-vaccine era and prevented a lot of patients from getting symptomatic SARS-CoV-2. We are now in a post-vaccine era where many people are protected because of vaccination. And so Evusheld is really targeted at people who don't actually get protection from vaccination, AKA our immunocompromised patients. And so this is something that you should ask your physician about if you're immunocompromised. And it is 2 shots, one of each of the monoclonal antibodies, and can provide protection that may last, 6 to 12 months. So a long duration of prevention of SARS-CoV-2. There are some caveats, and so because there's risks and benefits to every medication, this absolutely should be discussed with your physician. The biggest caveat in my mind is that this was studied in a pre-Omicron era. And so while we know how this works in a test tube against Omicron, and we know that it doesn't work as well as it did against previous variants, we do not know, and we have not studied it in people against Omicron specific. Quite safe. It looked like it prevented pre-Omicron variants to a quite high degree, but what we don't know is how well will it protect patients in the Omicron era or for variants that may still be coming. I still do recommend my immunocompromised patients receive this antibody, and I absolutely recommend that they discuss it with their physician. anytime you're going to get a medication that's under emergency use authorization, it's so important to hear the risks and benefits. And so prior to receiving that drug, there is information for each patient to hear more about that drug at the time of getting it. The last thing that I'll talk about in terms of what can our immunocompromised patients do to protect themselves has to do with after you test positive. If you have symptomatic illness, you've already, you may have gotten a breakthrough case, for example. Are there additional strategies we can do to protect against hospitalization, severe illness, and death? And early therapy, which are now more and more widely available, we are absolutely what I would recommend for patients who are immunocompromised and patients who are immunocompetent but are at high risk of bad outcomes if they get SARS-CoV-2. And those medications are being dispensed by many medical centers in the state of Utah, including the University of Utah. We recommend people contacting their physician or contacting our care navigation line to hear more information about those early therapies. We have two primary early therapies that we rely on. One of them is Paxlovid, which is pills, and one of them is sotrovimab at the moment, which is an antibody infusion. There may be more drugs in that space coming soon. There's been quite an explosion of things we can give to people either for early therapy or for prevention. And I suspect there will be more things in the coming future as well.
Great, thank you. And then we have a question here. What about the impact of age on vaccine effectiveness? Some countries have already started giving older adults a fourth dose. What do you know about that? Is that on the horizon here in the United States?
I don't know if it's on the horizon. We do know that age is certainly a risk factor for not responding to vaccines as well. And we know that not just with the SARS-CoV-2 vaccine, but we know that with previous vaccines as well. And it's an important population to actually study vaccines in. Most recently with, for example, the shingles vaccine was studied explicitly in an elderly population because we know vaccine responses aren't as good. I don't know if that's in the future as part of that immunocompromised group. It's not right now. And I will say, based on the data that we have, we still know that immune responses to vaccine is quite good, especially when you're in a community with other people who have been vaccinated. It's not, a 75-year-old and a 30-year-old will not have the same response to vaccine, which is consistent with what we know about other vaccines as well. So I think, it's very reasonable to watch that space. There may be updates in who is eligible for booster. But at the moment, elderly patients sort of fall into the general population unless they have another immunocompromising condition. Again, this may be something to discuss with your physician.
Great, thanks, Dr. Emily. I have a question here. Can you just talk about what percentage of the population are we talking about when we talk about either, those with chronic medical conditions, those who are immunocompromised, that group that is at risk of becoming severely ill from COVID? What percentage is that? And just a note here, we had a doctor, we had a press conference a couple of weeks ago. She's young and has a chronic medical condition and sort of put a face to this, saying it's, might surprise you. I think people have an idea in their head. These are people who look very ill, maybe they look older, and in fact, it's a lot of people. So can you take us through that a little bit? What percentage and who are the immunocompromised and chronically ill?
Yeah, in terms of putting a percentage, estimates I've heard, I may be wildly off. I'm going to say around 10% of people. This adds up to tens of thousands of people in the state of Utah. So we have done the math to look at the number of people, and it's a lot of people. Patients who are on immunomodulatory therapy, who are getting cancer chemotherapy, who have an organ transplant, who have a stem cell transplant. These are physicians. These are people that work in the community. These are students. These are teachers. These are children. They're really everybody, and it's very common to have someone in your life with a major immunocompromising condition, especially among patients who may not share that information or who are receiving one of these, chronic medical therapies that make their, that make their life livable, and they're able to function at a high level, which is the goal of these therapies, but at the same time, they're living with a chronic medical condition and a chronic immunocompromising illness that puts them at risk, especially if they are exposed, of severe outcomes from SARS-CoV-2.
Great, thanks, Dr. Emily. Do we have any other questions from media? Any other questions from our group? Then Dr. Emily, I'm going to hand it back to you. Do you have any final thoughts you want to leave us with today?
I think, there's a lot changing in the COVID-19, both preventative therapies, early treatment therapies, and they're all designed to keep people from getting critically sick and all designed to keep people from dying. I would recommend everybody listening, whether you're immunocompromised, immunocompetent, somewhere in between, to take advantage of all of the preventative therapies, especially vaccination, especially masking, because these really help decrease both the incidence of SARS-CoV-2 in our community and also the number of patients who are getting severely sick, who are dying, and who are leaving our community too soon. So this is my request for everyone listening to get vaccinated, wear a high-grade functioning mask, respect everyone in our community, and protect everyone in our community.
Thank you so much, Dr. Emily. If any of you need recordings, let us know, and any follow-up questions, please feel free to contact myself, Sue Winchester, Kylene Metzger. Thanks everybody for joining us.